A very good evening to everyone. On behalf of Andhra Pradesh Audiologists and Speech Language Pathologists Association, State Branch of Indian Speech Language and Hearing Association, I am delighted to extend a warm welcome to our esteemed speaker, Dr. Sujeet Kumar Sinha sir, and all the participants joining us for this webinar, which was organized to raise awareness on Balance Awareness Week. So again, on the behalf of Apaslpa-Isha, first and foremost, I would like to express my sincere gratitude to Dr. Sujeet Kumar Sinha sir for graciously accepting our invitation and taking time even out your busy schedules to be with us today. I would also express my gratitude to all the participants for attending this webinar. So without any further delay, we'll move to our today's topic, which focuses on basics of vestibular rehabilitation. We dive into this topic. I would like to give a brief introduction about Dr. Sujeet Kumar Sinha sir. So sir is an associate professor in the Department of Audiology, AlISH, Mysore, and he is also an AIB certified vestibular rehabilitation therapist. Sir has completed his post-graduation and Ph.D. studies at prestigious All India Institute of Speech and Hearing, AlISH, Mysore, Karnataka, India. He started his career as a faculty at KMC Mangalore in 2006, later selected as a permanent faculty in the capacity of lecturer in audiology in 2010 at AlISH, promoted to reader in audiology in 2015 and promoted to associate professor in 2019. He has 15 years of teaching, clinical research and administrative experience. He primarily works in the area of assessment and management of vestibular disorders. He teaches audiology to undergraduates and postgraduate students. He has also presented more than 60 scientific papers at national and international conferences and published more than 65 peer-reviewed papers in international journals. His publications are in very reputed journals such as Journal of Vestibular Research, a journal of prestigious Barney Society, and Frontiers in Neurology, the American Journal of Audiology, the Journal of the American Academy of Audiology, European Archives of Otorhinolaryngology, and Hearing Research. He has received many awards for his scientific paper presentations in national and international conferences in audiology. He has successfully guided 35 postgraduate students in master dissertation and is currently guiding 5 PhD candidates for their doctoral research. He is also first audiologist in India published a book on vestibular sciences. We welcome you, sir. It was really an amazing experiences you have mentioned. Thank you so much for joining today, and it's yours, sir.
Thank you, Sucharita.
Yes.
And I remember meeting all of you at the conference in Vijayawada.
Yes, sir.
I'm not able to see Gopi here. Is Gopi available?
He's there. Yes, he's available,
yeah,
sir.
Okay. Hi, Gopi. No, it's showing Del, so I'm searching with his name, so it is showing Del. Okay.
Yes,
okay, without any further delay, I'll start my talk. And this is the month of September, and third week of September is celebrated as Balance Awareness Week. Hope my screen is coming there now.
Yes, yes.
Yes,
it is showing, sir.
Okay.
Yes.
I'll just make it full screen. And before I start, at the outset, I would like to thank the Andhra Pradesh Association for Speech Language Pathology Association for inviting me for this talk. And I always say this, that I'm always thankful to my students, because whatever I learn because of them, and they make me every day what I am today, and I give them 100% of the credit always. Now, the topic which I'm going to deal with today is about the vestibular rehabilitation, because there will be many questions among the professional that how to go about the vestibular rehabilitation. So instead of talking anything a little advanced, I thought that I'm just only going to deal with some vestibular rehabilitation, of the basics of it, so that you understand that what is all about this vestibular rehabilitation, and how to go about it, who all are the candidate for the vestibular rehabilitation and who all are not the candidate for vestibular rehabilitation. So I'll cover first the basics, and probably sometime later we can look for the advanced aspect of the vestibular rehabilitations also. So now I have chose this area of science, that is the vestibular sciences, because you have to understand that vestibular, when I'm talking about the vestibular system, I'm all talking about the inner ear. And as we have learned from our first BSLP course, that any sensory damage cannot be recovered back, whatever it is. So if there is outer hair cell damage, there is an inner hair cell damage that cannot be recovered back. That is the whole science what we have learned. And similarly, what you have to understand is that the vestibular system is nothing but it's the part of the inner ear. So if the outer hair cell cannot be recovered back, similarly similarly the vestibular hair cells, once it is damaged, it cannot be recovered back. That is the basic which we have to understand. And what happens is that in certain cases there will be a good amount of compensation which will happen in the vestibular disorder cases, whereas some of the cases there will not be compensation. So when there is no compensation, central compensation, then it will become very difficult for the patient to leave. Actually, some of the videos are coming on my screen, which is little disturbing. Gopi, can you please look into that? Gopi, Sucharita, you are there? Hello?
Yes, sir. Yes, sir.
Some of the videos are appearing, some participants. It's little disturbing. Can you just put them off?
Sure, sir.
Okay, thank you.
Okay, sir.
So it becomes very difficult for the patients to live with that reeling sensation, wherein they feel that everything is moving around them, everything is rotating around them, or if they stand, they are going to fall, they are swaying. So it becomes very difficult for them. Yeah. So what happens is that the vestibular rehabilitation exercises will provide a good restoration of the activities which is restricted because of the vestibular damages. Now, the agenda of my presentation goes like this, that I'm going to present little data on how common is the vestibular disorders, the balance system, the most common types of vestibular disorders which are present, symptoms of vestibular disorder. I am not going to talk about vertigo because everyone knows that there is vertigo, but I'm going to talk about some other common types of disorder, the symptoms which are present in vestibular disorders, and then vestibular rehabilitation therapy and goals of vestibular rehabilitation therapy. This is what I am going to present. Now, when we look into vestibular disorder,
Unknown caller.
when we look into the age and gender, the vestibular disorder can affect individual of any age. I have patient as young as 5 years old, and I also have patient who are 85 years old. So I have that age range wherein I find my patients. And overall, when I look into, the females are more affected compared to males, and various populations wherein these prevalence studies have been done. In German population, it has been estimated at a rate of 7.4%, and in Korean population, it is roughly about 16.70%, and that's a big number. And in US population, people aged above 40 years, 35% of them have some evidence of balance dysfunction. And when I look into the data which I have, I mean, this is unofficial data, I don't have a published data, but unofficial data, when I look into my patient, almost 16 to 20% of the patients who are coming here for evaluation, they have some amount of balance issues. So you can consider that, even if you take that lower boundary 16%, India is a big country. Considering that, 150 crore population, you can estimate that how many people might have some amount of balance issues. And balance issues are again more prevalent in older population, which I see here, above 40 years basically. And it is lesser in children, or probably they are getting reported lesser in children. That is also, there is a possibility of that also. So now there are some of the common vestibular disorder, that is some of the common vestibular disorder which are present and which you will find in every day in clinic. Those are benign paroxysmal positional vertigo, the BPPV, the most common, and vestibular migraine, the second most common. And I'll say that now it is the most common disorder or most common population which we get here in my clinic: Meniere's disease, vestibular neuritis, labyrinthitis, and vestibular sonomas. If you are, if you look into all this disorder except for vestibular migraine, rest of the pathologies or rest of the patient which you will get, they have a unilateral vestibular disorder. This is the first thing which you have to understand. Unilateral vestibular disorder. Most of them have the disease which is confined to one of the side and there is no bilateral involvement. But what happens is that the vestibular disorders are not easy to diagnose. On an average, patient will consult at least 4 to 5 doctors before receiving a final diagnosis that yes, they have the problem. Now, here some of the terminologies I am going to explain, and these terminologies will help you to understand the things little later in my presentation. First is that brain compensation. The brain compensation is nothing but whenever there is a peripheral damage. Whenever there is a peripheral damage. When I say peripheral damage, the damage confined to the labyrinth, that is the inner ear, and the vestibular nerve. Then what happens is that there will be a rewiring of the central nervous system. Rewiring of the central nervous system is nothing but the rewiring of the brain, wherein the brain is going to compensate for the peripheral vestibular loss. That is, it is going to compensate for the inner ear damage, or it is going to compensate for the vestibular nerve damage. You have to understand.
कितना मना है इसके चौड़े छोटे आते हैं
Sucharita, can you just look into this sound? I request the participants, please mute your mic. It disturbs me here.
Yes,
Thank
sir.
you. So, what will happen is that there will be a rewiring of the whole thing. But the one thing which you have to understand, the sensory damage is damage. That means to say that if there is a loss of vestibular hair cell, the brain is not going to regenerate that hair cell. It is going to compensate the deficit which is occurring because of the vestibular system in some other mean. That's all. It does not mean that the hair cells will get regenerated. Hair cells, once it is damaged, it is damaged. Very simple. And I will give a simple example that what will happen is that, suppose for example, very simple example I will give. If we are going as a student, when we are going to the regular classes and we bunk some classes, when we bunk some classes, we don't get to learn what teacher has taught. But what we do, we take notes from somebody, or we ask somebody that what is that the teacher has taught, and we will take that notes and we will read. But that reading is a substitute which teacher has already taught, but we will not get those regular classes. So once it is damaged, it is damaged. You will not get that system back again, but there will be some other form of substitution which will happen from the brain. Now there are two phases of it. One is acute compensation. Acute compensation occurs from the cerebellar system, and it happens within 48 to 72 hours after the initial onset of the symptoms. After the initial onset of the symptoms. So this is acute compensation. This is also known as cerebellar clamping. I'm going to explain this phenomenon a little later. So this is also called as acute compensation, is also known as cerebellar clamping. Long-term compensation is nothing but it basically refers to the neurophysiological changes which happens at the vestibular nuclei and at the brainstem once there is a damage to the peripheral system. That means to say that there will be some kind of modification in the neuronal firing which will happen at the level of the vestibular nuclei or above, in order to compensate for the loss of the input which is coming from the peripheral system. This kind of compensation you see in the tinnitus. Now, what happens in the tinnitus? Very simple example you have to understand about tinnitus. Whenever there is a peripheral hearing loss, whether it is conductive hearing loss, sensory neural hearing loss, also you see. What happens is that the input to the brain is stopped. When the input to the brain is stopped, the brain tries to get that input. Brain tries to get that input from the lower system, that is the brainstem system. So in order to get that firing which was happening before the damage to the auditory system, it will open many channel, and one of the channel which opens, it opens from the dorsal cochlear nucleus. So from the dorsal cochlear nucleus, now the neuronal firing will be increased, but that neuronal firing is happening in the dorsal nucleus. It is not because of the cochlea, it is just an independent neuronal firing which happens there because the brain will try to compensate that loss, and hence because it is an independent stimulus, it will be heard as tinnitus. That is also a compensation, but that compensation is becoming tinnitus. That compensation here also happens in order to balance the individual. So you have acute compensation and you have long-term compensation.
Sir? Uh, Hello, sir?
Hello.
Hello,
Hello, sir.
can you
You're
hear me?
audible now. Yes, sir, you're audible now.
Okay, where did you hear last?
Compensation about this long-term acute compensation.
So the next important thing which you have to understand is VRT. It's a specialized type of therapy where we will use the active movements of the head, eye and the body movement to restore the central compensation and optimize the function in individuals. Okay, and this vestibular rehabilitation therapy basically is a customized therapy. When I say customized therapy, I am not going to follow the same protocol for every other patient. I am going to look at the deficits which are present in the patient, and then I am going to work accordingly. Such as few patients might have a deficit of VOR, few patients might have a deficit of VSR, and then if there is a VOR deficit, I am going to work on VOR, and when there is a VSR deficit, I am going to work upon the VSR. Now, decompensation is nothing but it is something like once the compensation has happened, but what will happen is that the brain will not be able to restore that compensated system or will not be able to maintain that compensated system for a longer time. What will happen is there will be a regression after having improved from the vestibular rehabilitation therapy. Now, if there is, remember this, if there is no compensation happening, that means say that if the central system is not compensating either in the form of acute compensation or the long-term compensation, or if there is a decompensation, the patient will require the vestibular rehabilitation therapy. The patient will need the vestibular rehabilitation therapy. Now, there are some possible triggers or causes of decompensation wherein once the compensation has happened and then decompensation happens. These triggers are basically the stress is the major factor, poor sleep, disturbed sleep, sickness, illness or new injury, diagnosis of diabetes which was not there, and if diabetes is there it is poorly controlled, visual impairment, one-sided vestibular problem becomes a two-sided vestibular problem, head injury, neck injury, spinal whiplash, fluctuating vestibular or central disorder, Meniere's disease, migraine-related vertigo, growing acoustic neuroma, perilymphatic fistula or canal dehiscence. So these are the factors or these are the disorders wherein there can be a decompensation. Now here I am going to explain you about the acute compensation, what is happening in the acute compensation. Now here from the peripheral vestibular system, the vestibular nerve fibers are supplied to the vestibular nuclei, From the vestibular nuclei, there is an input which is going to the floccular lobe of the cerebellar system. This is the floccular lobe of the cerebellar system. And back from the floccular lobe of the cerebellar system, there is another input that is being sent to the vestibular nuclei. The pathway between the vestibular nuclei to the cerebellar system is excitatory in nature, whereas the pathway between cerebellar system to the vestibular nuclei is inhibitory in nature on both the sides. So now whenever what will happen in the normal individual is that activities, that is the action potential on this side and the action potential on this side, it remains same. That means to say that it is a balanced input from or balanced output from both the sides. So here you look at the amount of action potential here and the look at the amount of action potential, it is approximately same. So the cerebellar system gets an equal input from both the side vestibular nuclei, and then it again generates a balanced output to the vestibular nuclei on both the sides. But what happens when there is a damage? Whenever there is a damage, there will be a lesser amount of generation of the action potential on the side where there is a damage. So you can see that there is lesser amount of action potential which is there. Now at this stage, the cerebellar system will get normal input from this side, but it will get lesser input from this side. When it gets a lesser input from the other side, this side, then what it does, it does not do anything on the affected side. Rather than what it does, that it will increase the inhibition on the normal side. When it will increase the inhibition on the normal side, automatically the activities from this vestibular nuclei is going to reduce, and it increases so much so that the activity whatever is coming from this side and the activity whatever is coming from this side again become equal at the level of floccular lobe. Now slowly what will happen is that the inhibition, you can see that the inhibitory pathway disappears on the affected side. That is nothing but whatever the inhibition is there on the affected side, that is not going to be there. Hence what will happen is that some amount of activity from here will increase to the cerebellar system. Now here what will happen is, because there is an increased inhibition here, now the activity here also decreases and the activities on the two sides becomes same. This is what happens in the acute phase, and this acute phenomena takes place around 48 to 72 hours. During this acute compensation, what will happen is that the vertigo will disappear, the nausea will disappear, the vomiting will disappear, but the patient will report of imbalance. That is where whenever any patient is coming to you in your clinic, typically they will tell you that I had a vertigo attack. They will never say that I have a vertigo attack. They will say that I had a vertigo attack 3 days back, 5 days back, I was hospitalized, I was there in the hospital for a week, I was there in the hospital for 3 days, 5 days, and then I was fine, my vertigo has reduced, but I am having an imbalance. This is the reason wherein the vertigo will reduce, but the imbalance will persist. Over the period of time, the cerebellar system is further going to calibrate the whole thing, and what will happen is that because it has taken off the inhibition on the affected side, this affected here, the labyrinth, there is not going to be any change. Whatever the calibration is happening, it is happening at the level of the vestibular nuclei. So now slowly what will happen is that the activity on this side will still continue to grow because there is no inhibitory system here now, and slowly what will happen is that this inhibitory pathway will start becoming little weaker, so that activity on this side also increases. So at this point of time, the patient will not have vertigo, at all, no vomiting at all, but will have imbalance. And also the patient will find very difficult to walk on the soft surface during this time, on the uneven surfaces during that time, and will find very difficult to climb the staircase, and even find very difficult to walk in the dark, okay, during the acute compensation phases. So what will happen is that the cerebellar system will fine tune the activity of the vestibular nuclei, not of the labyrinth. It doesn't do anything to the labyrinth. Labyrinth, once there is a damage, there is a damage. It does not do anything. So it will fine tune the activity on a permanent basis. Okay, it will permanent basis. That is the long term changes which going to occur at the level of vestibular nuclei and the brainstem. Now, the type of vestibular disorder, that is the characteristics, what will happen and what can be the extent of recovery, that I am going to talk about that here in this slide. So now if there is a spontaneous nystagmus in the patient which you see at the onset of the vestibular disorder, it will decrease at 1 week, but largely, but it will be incompletely recovered at 1 year time. It will take time to recover the spontaneous nystagmus. And in the peripheral vestibular pathology, the spontaneous nystagmus will be present in eyes closed condition. That is, you cannot observe it when the patient you are talking. Have you seen any patient having nystagmus? Say that you have seen that a patient with Meniere's disease. Have you seen any point of the time any nystagmus in them? No. Unless and until you use the VNG goggles or use a pharyngeal glass, you will not be able to observe this nystagmus. Okay. Then skew deviation will resolve within a few days. Caloric nystagmus, that is nothing but the caloric, because the hair cells will be dead. Once the caloric responses shows hypoactivity, it will be a permanent loss. It is not going to recover at all. So caloric you do now, if you see that it is abnormal, after 1 year also you do, it will be abnormal only. Vestibular evoked myogenic potential, similarly there will be a permanent loss and it cannot be recovered back. The vertigo will get resolved within a few days. I told you that within 48 to 72 hours the vertigo will disappear. That is nothing but the spinning sensation which the patient will have, that will disappear. Okay. Now in the episodic vertigo, it will keep coming over the period of time. That's all. Otherwise, in remaining of the pathology, it will get resolved within a few days. Now, postural disequilibrium at rest, not during the walk, it will reduce, but incompletely it will get resolved within a year. Now, the VHIT test, that is the video head impulse test, there will be little change over 1 year. That is nothing but if the VOR gain is reduced, it will be reduced only. The VOR gain is not going to become normal. There may be a presence of more corrective saccades. Presence of, I repeat, corrective saccades in the video head impulse test, which you will find over the period of time, but the VOR gain is not going to recover. Now, there are some symptoms of impaired VOR. Now, always we talk that, what happens in the vestibular disorder. We say that there is vertigo, there is imbalance. I'm not going to talk about vertigo and imbalance because everyone knows that there is a vertigo, there is an imbalance. Here I'm going to talk about what are the practical problems which the patient is going to face over here. So the symptoms of impaired VOR is difficulty in reading or difficulty in focusing with the head movement. Now, this patient might tell you that whenever I am walking on the road, I find very difficult to read those signs on the road. That is whether it is left, whether it is right, or when it is written that turn to the right, it is not clear, it is blurred. Very simple. So that they will find it very difficult. Then difficulty in reading signs while walking or driving. Then difficulty in side to side head turn. So when they move the head from left side or right side, they will find it difficult. In bilateral vestibulopathy cases, wherein there is a complete damage to both the vestibular system, you can say that profound hearing impairment, here you can say that profound vestibular impairment, they will have problem in chewing or eating while watching television, may be bothersome for them. So they will find it very difficult. Now, some of the problems which the person who have an impaired vestibulospinal reflexes, they will not be sure of footedness. That is where I am keeping the foot. That is, if they have to climb the staircase. So if the staircase is equally there at 6 inches, they will not be sure that whether it is 6 inches or 5 inches, whether when next I am going to keep my foot, whether I will keep it properly or I will not keep it properly, they will not be sure. Then there will be an impairment of the coordinated movements. And then preference of surface. Preference of surface means they will always want to stand on a hard surface and they will not want to stand on a soft surface. They will always want to stand on a flat surface, not on uneven surfaces. Then falls is common, the sway is common, and it can be preceded by VOR symptoms that have already resolved or improved. That means to say that the VOR symptoms and the VSR symptoms may not occur together. The VOR symptoms might occur first, it might improve, but VSR symptoms will also start at a later point of time. And because of this VOR and VSR problem, it will diminish quality of life for the person. Now, if I stand and I feel that if I stand, I'm going to fall down, or if I walk, I feel that I'm going to fall down on my right side or I'm going to fall down on my left side. Whether I would like to walk? No. So, similarly, it will happen for the patient that if they feel that they are going to stand, when they stand, they are going to fall, they will not want to stand. They feel that they are going to fall down when they walk, they will not want to walk. Very simple. So it will diminish their quality of life. They will not want to go out of home. They will not want to attend any social events, social functions anywhere. So they will have a very restricted life. If they feel that, for example, another thing, if they feel that if they are going to move the head, the whole world is going to spin around them, then they will not want to move their head. That is as simple as that. Then there will be a decreased muscle strength. Now decreased muscle strength will be there because of the reduced VSR. Then there will be reduced stamina and there is going to be a fatigue factor which is going to come. Always they will feel frustrated that they are not able to do any work. Now VRT, that is vestibular rehabilitation exercises. The purpose of the vestibular rehabilitation exercises is basically to reduce the vertigo and the dizziness, what they are feeling. That is to reduce the vertigo also, to reduce the giddiness also, to reduce the imbalance also, to reduce the gaze instability. That is nothing but what they are finding that yes, during the head movement I am finding it difficult to read. This all kind of gaze instability it will reduce. Then reduce the fall risk at the last and improve the ability to focus or concentrate on the things. These are the goal of the VRT exercises. Additionally, I told you in the beginning that there will be a customized approach. All the patient, I am not going to do the same exercises. I am going to look at the person's problem, whether the problem is related to the VOR or VSR or both, and according to the problems I am going to work upon that patient. Now if I have a patient who says that I have only imbalance issues and I do not have any kind of a spinning sensation wherein I don't find that the world is rotating around me, then what I am going to do is that I am going to work upon only improving his or her balance function. I am not going to work upon anything, or I am not going to introduce any exercises wherein it works upon the spinning or the rotations. Now again, here what will be done is basically it will eliminate or reduce the symptoms by stimulating the central nervous system. The idea behind the whole VRT exercise is that you are giving some exercises, to brain basically, because the peripheral system is already damaged. So once it is damaged, it is not responding to what you are doing or what the patient is doing. So here the idea is that stimulate the brain so that the brain understands that there is some problem and brain is going to compensate for that imbalance. Now for many patients, the vestibular disorder, the compensation from the central nervous system will not occur. Many patients it will happen, wherein it will happen they will not require the VRT, but wherein it doesn't happen, then what will happen is that you have to go ahead with the VRT basically. Now, three types of exercises which will be basically taken up. The first one is gaze stability exercises, wherein there will be the gaze stability will be restored, which is a problem for the patient. So here what will happen is that the idea is to promote the vestibular adaptation, which involve the head movement while maintaining focus on a target which may be a stationary or moving. Very simple. I'll make you understand that. Yesterday also I was talking about the head impulse test. Now here in the normal viewer, what happens is that whenever I move my head to the right, my eyes will go to the left, and when I move my head to the left, the eyes will go to the right. This is a normal viewer function. Now suppose if a person has a right side vestibular disorder, then when the person will move the head to the left, the eyes will correctly go to the right. But when the person will move the head to the right, the eyes will also move to the right, it will not come to the left. Now you have to restore this function. So when you have to restore this function, basically you have to maintain that focus on a target, so that you have to say that this is your target and you move your head right and left focusing on the target, so that this kind of deficit which the person is feeling is getting compensated over the period of time. And this will be performed with head movements in the horizontal plane as well as in the vertical plane. That means say that left, right and up and down. The second set of exercises are habituation exercises. Habituation exercises. Now, habituation exercises which you have to simply understand. Now, I don't know, nowadays the teacher will not beat the kids basically. But when I remember my time, it used to be like, every day we have to get like a prasada, tirtha from the pujari. It is like, it was like that only in our time in the school. So at that point of the time when we were going to the school, on the first day when the teacher would beat, we will say that he is a devil. The second day when he is beating, we'll be like, okay, he's beating, it's okay. Third day when comes, then we'll say that, okay, he's like that only. Fourth day onwards, we will just give the hand, the teacher will beat, and then we will not feel anything. That is nothing but the repeated exposure to a specific stimuli will take away that pain basically. That's all. So here in the habituation exercises, you have to understand two things. One is the patient who will move more, they will improve more, number one. Number two, the stimulus which is noxious to the patient, that means say that the one which is creating the problem to the patient, you have to expose the patient to the same stimulus once again with little cautions. That is always there, that you have to, with a little cautions, this one you have to do it, but you have to expose the patient to the same kind of a stimulus. Suppose for example, if a patient says that if I move my head to the left and right, I feel that the whole world is spinning around me. So now you have to design the exercise in such a way that wherein the patient will start moving the head in left and right side only, towards the left or towards the right, slowly. Maybe you can say that 1 per second, then go for 2 per second, then go for 3 per second, then go for 4 per second. So you have to perform several repetitions of the same task, so that whatever is there, there will be a habituation which will occur over the period of time, and because of which, even though there is some amount of vertigo or giddiness which is present, the patient will not feel that. Okay, so that repeated exposure to provocative stimulus or the noxious stimulus, again and again you keep repeating, that will take away the vertigo and the giddiness from the patient. It is as good as the auditory training. Speech therapy, you go on repeating the stimulus, the child is learning to hear, the child is learning to listen, the child is learning to speak. The same thing it's here, that's all. Now, many recent approaches involve the use of optokinetic stimulus or the virtual reality environment, such as habituation exercises. Such as, for example, many of the normal individuals also have motion sickness problem. So when they have motion sickness problem, virtual reality is the one wherein it works, I'll say that the best, wherein what happens is that you create an environment, virtual environment, wherein they feel like they are sitting in a car and they are moving in that environment, and they are having that feeling of vomiting or sweating while they are moving. So you keep exposing them to the same environment, but in a virtual this one mode, so that what will happen is that that feeling of motion sickness will disappear over the period of time. The third part is the balance training. So the gauge stability, the habituation exercises, and third one is that balance training. Now, balance training will be done under different altered visual or somatosensory input, such as, for example, if I am making the patient to stand on one leg, first I'll ask them to stand on a firm surface. So one leg, they will stand on one leg on a firm surface, eyes open. That will be the first condition. Then I'll make them to stand on one leg, then eyes closed on a firm surface. Then third part will be I'll make them to stand on a foam surface, that is a soft surface, then one leg up and then eyes open condition. Then the next will be I'll make them to stand on a foam surface, one leg up but both the eyes closed. So you go on cutting down the cues, that is you cut down the visual cues, you cut down the somatosensory cues, so that the patient will learn to balance over the period of time. Okay, and this will may involve changes in the base of support to increase the challenge basically. So what I do is that I also make them to stand on a foam surface and I'll ask them to do the Romberg test on the foam surface, the sharpened Romberg on the foam surface, wherein they keep their leg in the tandem gait position and they will stand there. So you go on cutting down the visual cues, you go on cutting down the somatosensory cues, and you make them to balance themselves. And once you are done with all this, you go for general conditioning. General conditioning is nothing but wherein the patient feels that I stand, then I feel imbalance. I walk, then I feel imbalance. Or if I walk, I feel dizzy. So what I will do is that I will make them to walk. So we have a big corridor there. So I'll make them walk first. Okay, you walk with eyes open. Then I'll ask them to walk reverse, that is backwards. Then I'll ask them to walk with eyes closed, so that they get that confidence that even though there is a darker situation, they can walk. So I'll ask them to close the eyes. I'll be there with them when they are walking, and I'll make them walk. I'll make them to climb the staircase. I'll make them to get down from the staircase. So the general endurance is very much important. The general conditioning is very much important, because the patient should, after the exercises, the patient should get that confidence that yes, I am walking and now I am not going to fall down. Now I am able to walk wherein I don't have a sway, I don't have a dizziness. Because any patient who has giddiness or who has vertigo, if you say that you are going to make them to move their neck left and right, up and down, eyes left and right, eyes up and down, and they will become fine, who is going to trust you? Nobody will trust you, because they would have visited already a number of professionals and their condition has not become better, and that's why they have visited you. So everybody will have that feeling that when I went there, I had medicine and it is not able to cure, whether these exercises will cure. That is where the general conditioning is important, wherein you have to give them that confidence. See, you are doing the exercise, now you are becoming better. So you walk, you are climbing the staircase now, you are able to walk forward, you are able to walk in a reverse order, you are able to walk with eyes closed, you are able to walk with eyes open. So you have to give them that confidence of standing and confidence of walking without any problem. Now, who is VRT for? Whom we are going to do the VRT and whom we are not going to do the VRT. Now, VRT is not for the patient whose vertigo is in acute phase. Remember this, I always tell to my student that any patient who has acute vertigo are the cases of the medical emergencies. They are not the cases of the vestibular emergencies. So if you find that the patient has an acute vertigo, please refer them to a medical setup. Don't go on doing your vestibular testing and diagnosis and rehabilitation. It is of no use to the patient first. So any patient who have the problem in the acute phase, please don't touch them. Just send them to a nearby medical center so that their problem is solved. Debilitating vertigo, wherein they have that severe vertigo wherein they are not even able to stand on their own, do not go for VRT. First let them go for a medical consultation and then you see that what is happening. Now, in the mid of the vertigo event to labyrinthitis or neuritis or active Meniere's disease will receive little or no benefit from the VRT. one thing which you have to understand, the VRT will not be beneficial for any patients who have this episodic vertigo. That will say that the VRT will not be useful for menials, or VRT will not be useful for the vestibular migraine patients. Okay, but neuritis and labyrinthitis, what you have to understand is that VRT will work only when there is an acute compensation which has happened. So if the acute compensation has happened, because initially when they will have the severe vertigo in labyrinthitis or neuritis, they will go to the nearby medical center, and then 3 to 4 days they will be there in the hospital. They will be out of hospital, their vertigo would have reduced, their spinning sensation would have reduced, vomiting would have reduced, but they will have the imbalance. So they will come back to you after a week or 10 days saying that I am having this imbalance, I had a vertigo attack. Then they are going to benefit from the VRT. When they are there in the medical setup itself, don't start with your VRT. That is not going to help. Now, VRT is for more for a stabilized condition. A stabilized condition, when I say that they are not there in the acute phase, they don't have vertigo anymore, and now it is more of imbalance over the period of time, then they are going to receive the benefit. Then the VRT is also for vestibulopathy, wherein there is a complete damage of the vestibular system, that is nothing but a profound vestibular impairment. They are going to benefit from the VRT. The VRT patient of Meniere's disease who are in burnout phase. Now, burnout phase, you have to understand is that, like how there is a severe hearing loss, profound hearing loss. Similarly, what will happen is that in the Meniere's disease, there will be a cochlear hair cell loss. Also, there will be a progressive vestibular hair cell loss. The progressive vestibular hair cell loss will reach to one stage wherein there will be little or no surviving hair cells inside the vestibular labyrinth in these patients of Meniere's disease. So what will happen is that the vertigo will disappear altogether. Now they will have more of an imbalance. So when they reach to the burnout phase, wherein the spinning sensation will reduce, the episodic vertigo will reduce, but there will be an imbalance. But this burnout phase will happen maybe somewhere 5 to 6 years down the line from the initial onset. So any patient whom you are seeing for Meniere's disease over the period of time, you will realize that the first the vertigo will be progressive in nature. It will progress over the period of time, and then it will start coming down slowly. So when it is a start, it will start coming down slowly over the period of time. It will disappear also, and they will be left out with only the imbalance issues. So these patients with Meniere's disease are going to benefit from the VRT, that is vestibular rehabilitation therapy. But also what is important is that you take the present history, present illness history. That is nothing but once you decide that yes, I am going to start with the VRT now, you have to understand the present condition of the patient. That is any vertigo which is happening because of the head motion. That is one thing. Second thing, how is the vision? Whether the images have become blurred because of the problems, or whether the images are clear still. Then body position is nothing but whether they are able to stand properly, they are not able to stand properly, they are able to balance themselves, they are not able to balance themselves. Head posture, how is the head posture? Whether the head posture is leading to any kind of vertigo, or it is not leading to any kind of vertigo. That is the present illness history. You should always understand, so that you understand that what is the kind of problem you are dealing with, and what is the kind of exercises that you are going to give to the patients. Now the treatment protocols are like this. So if there is an oscillopsia, then you are going to work upon the gaze stabilization exercises. Oscillopsia is nothing but whenever there will be a bilateral vestibular impairment, what these people will feel that whenever they move, the whole world is also moving with them. That is, it is moving up and down, left and right with their head movement. That is the first kind of feeling they will have. So when they have this oscillopsia, you have to go for gaze stabilization. When there is a mismatch of the information is nothing but what will happen is that you have three systems. You have visual system, vestibular system, and the proprioceptive system. So the visual system and the proprioceptive system is normal, but the vestibular system is affected. Then there will be a mismatch of the information. So when there is a mismatch of the information, you have to go for optokinetic stimulations or you have to go for virtual reality. When there is an increased sensitivity to the head movements, that is, they say that whenever I move my head to the left and right, I feel imbalanced, then you have to go for habituation exercises. When they have that imbalance problem, that when I stand I feel that I'm going to get imbalanced, then you have to use the challenging surfaces and you have to make them to stand on the challenging surfaces with both legs, with one leg, and mostly what is going to benefit them is the one leg stance. So they stand on their left leg first, then they stand on their right leg, and they stand on the firm surface, then they stand on the challenging surface, that is the foam surface, and that is how the balance will get corrected over the period of time. Apart from that, you make them to climb the staircase, then you ask them to get down the staircase, but always remember, whenever you are performing the VRT, you have to be always there with the patients. You cannot leave them that okay, I am standing here, you go climb the staircase and come back, because in between if they get vertigo, if they feel dizzy, then it will become difficult for them and it will become difficult for you too. Then cut down the visual cues along with the proprioceptive cues whenever there is an imbalance. Now also increase sensitivity to the head movements, you have to go for multiplane stimulation. That is means to say that the head movements you do not have to give only in the left and right directions or the vertical direction, that is the horizontal and the vertical directions, but also a multiplane stimulation which you have to create for these patients. Now, it is always good to have some outcome measures whenever you are doing the VRT, and these outcome measures, primarily if you ask me what I am doing, I am administering dizziness handicap inventory. So the patient, the first day when they are coming to my clinic, and if I plan that yes, I have to go for VRT for this patient, I'll give them this dizziness handicap inventory to fill in. And once I am done with the VRT, wherein the patient says that now I am okay by 80-90%, then I'll give them to fill up once again. So that will give you exact idea on which aspect they have improved and which aspect they have not improved. So some of the outcome measures you always have to perform, because you may be doing something, you may be feeling that the patient is improving, the patient might be feeling that they are improving, but what is that aspect that is improving and which aspect they are not improving, you will get the correct idea once you administer this handicap inventory or this dizziness questionnaire. Also, whenever you are performing VRT, you must use some cognitive tasks to improve them. That is, one of the tasks which I use is that word stroop task, wherein they have to say the color and not the word. Such as, for example, say they have to say the color and not the word, that is, this is red and this is not blue. So the patient has to say that this is red and this is blue and this is green. They have to say the color, they don't have to say the word. So some of the cognitive tasks wherein their attention should improve. So that is where I use this stroop task. So here they have to say that this is green color and they don't have to say me that this is yellow and this is blue and this is also blue. So they have to do this, perform this task. Also, some cognitive task which I give to improve attention is short-term memory recalls. The complex movement patterns, wherein I just create some movement pattern. This will be already available on online, many things, and I'll say that if the image was moving, you tell me that whether it was moving left to right or whether it was moving right to left or up and down. So again, I'll repeatedly show them this one, and then I am going to ask that yes, what is that is going to what is that you saw that what was happening on the screen. Then I give some mathematical task if they are educated. So mathematical task I give them is simple, say that calculation, addition, 5 plus 2, 10 plus 2, or 100 minus 7, 93 minus 7, and then 86 minus 7. So that is how I give them some mathematical task, some question answer to divert their attention and make them focus on the VRT. Now, the vestibular rehabilitation exercises, overall you have to understand that the purpose is to loosen up the muscles of the neck and shoulder. That is the first thing, because what will happen is that once they understand that they are going to move the head left and right or up and down, they are going to get this spinning sensation. They will stop moving their head. So once they stop moving their head, what will happen is that they will start getting the neck pain basically. And this neck pain can radiate and it can create pain in the shoulder. So that you have to loosen up the muscle, and so that the pain, whatever is there, that goes off. Number one. Number two, they will mostly move in one piece. Mostly move in one piece means if they have to turn towards the right side or turn towards left side, they will move the entire body to the right side or entire body to the left side rather than moving the head alone. So your purpose should be that they should move their head independent of the body movement. And again, the second thing is that you have to train the movement of the eyes. That is, they should be able to move their eyes horizontally and vertically independent of the head. Independent of the head. That is, that the head, they should keep it constant, but they should be able to move their eyes properly. They should be able to track a stimulus. Okay. Then to practice balancing in everyday situation with a special attention to developing the use of eyes and the muscle sense, and to practice head movement that causes dizziness and thus gradually overcome the disability. These are the purpose of the vestibular rehabilitation exercises. Now the vestibular rehabilitation exercises, just 1 second. Okay, so day one, whenever I start the vestibular rehabilitation exercises. I make them sit in a chair, but this chair should not have armrest. So the chair will not have the armrest. They will sit there, and typically you can see that dining chairs available in our home wherein they don't have the armrest. So they will sit there, and first I am going to ask them to do is the eye exercises. So they have to move their eyes horizontally and vertically. So I'll say that 20 times you move your eyes to the right side and 20 times to the left side, and then up and down. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So here what I am doing is I am asking, or I am moving the eyes independent of the head movements. The head is constant, but the eyes are moving left and right. Similarly, I'll ask them to move the eyes up and down. So 20 times up, 20 times down. So they will be doing like 40 counts: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So on, they will do 20 times. So up and down, side and side, and then repeat A and B, focusing on the finger at arm length. That is nothing but you keep the finger here around 1 feet away, and you ask them to move their eyes focusing on the finger. So what will happen is that here you ask them to move the eyes here, and then simultaneously now you teach them to move the head with focusing on the finger. That is, they turn their head to the right side, but they are focusing on the finger. They turn their head to the left side, they are focusing on the finger. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So on they go on. Then head exercises, at first slow, then quick 20 times. So first slow and quick means a simple head exercise with eyes open and eyes closed. That is 1, 2, 3, 4, 5, 6, 7, 8. So on 20 times, and then 1, 2, 3, 4, 5, 6, 7, 8. Then 20 times they have to do that. Then eyes closed, and then they have to do 20 times. 1, 2, 3, 4, 5, 6. So on 20 times, and then vertical 1, 2, 3, 4, 5, 6, 20 times. Also they should move head and the finger again together. That is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, so on. So this is what is the exercise which is given on day 1 if they have BOR deficits. And after that they will be given shrugging of shoulder to loosen up the muscles here. So what they will do is 1, 2, 3, 4, 5, and then rest, and then 1, 2, 3, 4, 5. Okay, so on. They have to bend forward and pick object from the ground 20 times, but For picking up the object, you have to really look at the physical condition of the patient, because if there is an old patient, I will not typically go ahead with this exercise with them. Then rotate head and shoulders slowly, then fast 20 times, and then rotate head, shoulder and trunk with eyes open and then close 20 times. That is a complete movement of the body. Okay, so right and left, eyes open, eyes closed. So they have to move right side, they have to move left side. Okay, this is the first day exercise which is being given, and then they have to, the second day onwards, they have to go for a standing exercises, and in the standing exercises they have to do all the first day exercise. But first day I told you that they are sitting in a chair and doing these exercises. On the second day they will be standing and doing that exercises. All the exercises they will repeat, but they will be standing and doing it, so that you understand. Then again, next, throw ball from hand to hand above eye level 10 times. Throw ball from one hand to the other hand underneath 10 times. Change from sitting to standing and turn around in between 10 times. Repeat head, shoulder and trunk rotation with eyes open and closed 20 times. Then walking, walk across the room with eyes open, then closed 10 times. Walk up and down slope with eyes open, then closed 10 times. Do any games involving a stooping or a stretching and aiming, such as bowling, shuffleboard, etc. Stand on one foot with eyes open, then closed. And many times I told you that on a firm surface first, and then you have to go for a foam surface. Wall with one foot in front of other with eyes open and then eyes closed. So these are the different kind of exercises which is being done. But what you have to understand is that these are not the only exercises which has to be done. These are some of the exercises which I have put in my presentation. You can think of anything which can improve their VOR function, improve their balance function. You can customize it, you can design it, and you can do it. Such as, for example, one of the easiest thing to improve the VOR function is that earlier that old movies used to show that, you know, the the actor or the actress will take that, what is that called as, on the board they will throw it and they will say, loves me not, loves me not, or loves me so. Okay, so that what will happen is that this is focusing on the target, and this, if you make the patient to do it on the board, what will happen is that it will improve their attention also, and it will improve their VR function also. Such as, you have some balloons and the heat keep hitting the balloons in different directions, so that head will move, eye will move, hand will move, so the hand eye coordination will move. Okay, as simple as that. So that also can improve the VR function. So there is no limitations of the exercise that you have to follow only this exercise or that exercise. You can think, you can be creative on your own way, that you see that where you can create head movement and eye movement, you can do some exercises with the patient. It is going to improve, or it is going to benefit the patient. Okay. So this is typically my audience at 6 p.m. So thank you so much, and if there are any questions I would like to take up. And believe me that I have just talked the basic, and you definitely requires at least 3 to 4 hours of sessions in person, not online, in person, to understand the whole process and the whole rehabilitation exercises which the patient has to go through. So you must look into that, and you also have many lot of videos which are available on the YouTube demonstrating the VRT exercises. That also you can look for that practical aspect of it. So if there are any questions, I would like to take up.
I request the participants to ask your questions by unmuting your microphones. So there were few questions. I'll just read out. Please throw some light in your experience, if any, for vestibular issues and assist or manage in blind or people with single eye blindness.
Yeah, here what will happen is that in the blind individual, or single eye blindness still will be okay because they have some visual input. But if I consider the blind individual plus having a vestibular issues, then you have to understand that along with one of the system the other cues are also cut off. So that means to say that you have to work more upon the VSR to restore their imbalance, and you also have to work upon the VOR to restore the VOR restoration, in the sense that the anyway the image is not there, but what will happen is that for the head movement, what will happen is that for the head movement, the kind of giddiness or the dizziness which they are feeling, it will reduce over the period of time. Okay, but here what will happen is that you should not go for, in the blind individual, you should not go for additionally cutting off the other cues. You have to give them the cues and you have to make them balance themselves. So you can go ahead with the exercises, one leg stance, but what will happen is that you should not cut down then the proprioceptive cues more to create more imbalance in them, and they will not they will get benefited, but what will happen is that it is very difficult for them to balance with cutting down the proprioceptive cues again.
So one more question, are there any modifications in material used for individuals with vestibule issues and are uneducated?
Material used, yeah, see what will happen is that foam surfaces which I was talking about, that foam surfaces are there. Now everybody may not have that ideal foam surface which they have. They can use the sofa cushion as good as that. They can use the sofa cushion, they can use the pillow to cut down that the proprioceptive cues while you are teaching them the balance exercises. Okay, or you are making them to balance themselves on the softer surface. You can definitely make use of those sofa cushions, make use of pillows, because everybody will have invariably pillow or a sofa cushion at home. So that is how the material modifications which we have to go ahead with.
Specific modifications in pediatric with vestibular migraine or any other vestibular issues, please.
Vestibular migraine, most of the time it is lifestyle modification rather than the VRT. Now, some of the lifestyle modifications, I'll say that vestibular migraine will require twofold of rehabilitation. One is a medical line of treatment, and second is going to be lifestyle modifications more rather than going for a VRT. And the lifestyle modification includes, number one is reduction of stress. That is the first thing. Nowadays, what happens in the pediatric population, because most of the children who report to me, they have a vestibular migraine. And this vestibular migraine, what is happening is that nowadays the expectations from the child, has increased. Parents have their own expectations, teacher have their own expectations, a school have their own expectations. And nowadays I find that even LKG or UKG kids have 3 kgs or 4 kgs of heavy bags. Whereas when I was even in my 10th class, I used to just carry one notebook to my school and I used to go sit there, write something, come back to home, happily play with other kids, and that used to release the stress. Whereas here what is happening nowadays is that the children are going to school, coming back to home, getting locked inside the home, they are not getting that environment. Weeks together they will not get to play with the other kids. So where this stress goes? So you have to modify these stress conditions, take them out more, so that they are going to the nearby park, they are meeting the kids, they are playing with the kids, leave them to play for 2-3 hours. Now that has become again a problem in the present scenario, because where do you leave your kids? That is one problem. Where do you take them? With whom do you leave them? That is another condition. So most of the time these kids are lost. So one thing is that reduction of stress, management of stress in the kids, that is major thing. And then they should have a proper sleep. That you have to look into that. You make them sleep a little early and find a particular pattern of sleeps. That is nothing but if they go to bed at 10 o'clock at night, you ensure that every day, 30 days of a month, they go to bed at a particular time. That's all. So you have to make that a particular pattern of sleep for them. Then food, that is nothing but all the 3 times again you give them food at particular times only, that yes, they are eating and they are eating at this time. Major problem, mobile phones, the screen. You should keep the children who have these vestibular issues away from the screen, because this visual, there will be a visual trigger when they are looking at the moving screen. that the trigger that will act as a trigger, and it can just activate or that increase the vertigo, or if the vertigo is there, it is going to increase the vertigo at that point of the time. And at least there should be a gap of 2 hours between the screen time and the sleep time. That is, you should switch off all the television, you should switch off the mobile, you should switch off the laptops. They should not be able to see any screen 2 hours prior to the sleep. Plus some food habits, anything to do with the caffeine, they have to reduce the caffeine. Dark chocolates, children and chocolates, you know that, you know what is the combination, but the chocolates you have to remove. That is what is there. These dark chocolates particularly are a big trigger to the migraine. Coffee, tea, okay, marinated foods, because all of us have that habit that, you know, put some chicken pieces or put some paneer pieces into yogurt, mix it 3 hours, you marinate in the fridge and then cook it. That marinated food, it's a trigger for individuals with migraine. Soya sauce, food that contains monosodium glutamate. These are the things which has to be worked upon for lifestyle modification in children with migraine. That is there.
So next question, can you please explain the role of attention and balance? Why do you insist on working on attention?
Yeah, okay. Now what will happen is that you want to bring their attention to what you are doing, because what will happen is that these individuals most of the time, because they know that they have the problem, they will be thinking that, you know, what has happened to them, whether they have something serious in the brain that is causing that problem, they have some serious heart issues, and even they understand that no, 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 there is no brain issues or there is no heart issues. What will happen is that whether this problem what is there can lead to the brain disorder or can lead to the heart failures, so they will have multiple thinking which all together. So even though you are doing the exercises, they are somewhere, that means say that their mind is somewhere, they are thinking about the problem, they are thinking that again tomorrow morning if I get up I will have a spinning sensation again, if I stand I am going to fall down again. So you have to bring that attention, that, you know, what you are working upon, they should be concentrated here, and what you are asking them to do or whatever exercises you are doing with them, they should be able to do it properly. That is where you have to work upon their attention, and their attention is very much affected. Attention, why it is affected is that most of the time they are thinking about their problem, they don't have that confidence to stand, confidence to walk, confidence to do anything, because it is definitely hurting them or definitely making them disabled. That is where you have to work on the attention.
How to differentiate or assess the acute stage of dizziness?
Now, what will happen in the acute stage of dizziness? Most of the time, they will have a very severe vertigo, and they will not be in a position to stand. Basically, they will not be in a position to stand. This acute vertigo can be because of a peripheral disorder or can be because of a central disorder. Now, what will happen is that in the peripheral disorder, most of the time it is caused by a vestibular neuritis or it is caused by a vestibular labyrinthitis. Whereas in the central disorder, most of the time it is caused by pica infarct, which I also call it as posterior circulation infarct, that damages a particular part or particular area of the cerebellar system. Now the symptoms are going to be same. The symptoms in the patient with vestibular neuritis or a posterior circulation infarct, almost it is going to be same. They will have a very severe vertigo. So first they need to be admitted to the hospital. They'll be there in the hospital. The hospital, first they will do all the scan and everything to rule out whether there is a peripheral disorder or the central disorder. And once they are out of hospital, you have to remember that I told you that the acute compensation is going to occur within 48 to 72 hours. So once they are out of hospital, they will come out on 4th day or 5th day or after a week, and then definitely they will be there at home for some time. So say that 10 to 15 days down the lane only they will come to you. So at that point of the time, the acute stage would have got over basically when they report to you. That is where the spinning sensation basically which was there, wherein they're feeling that everything was rotating, will come down. It will be more of imbalance. So you have to understand from there is that now the acute stage is over. Now the second stage has started, wherein there is some amount of compensation, and you have to facilitate this compensation by using the VRT.
Persons with BPPV different maneuver for different type of BPPV would be enough, or VRT would be suggested post maneuver?
I'll say that 90% of the patient with BPPV, they will become better with the maneuver only. And another 10% of the patient with BPPV, they might have post maneuver some amount of dizziness which is going to persist. If they have post maneuver some amount of dizziness, not the spinning sensation. If the spinning sensation is persisting, you have to go again for the maneuver only. That will say that there was some mistake in doing the maneuver or identifying the canal. That's why you are not able to do it properly. But if they have some amount of dizziness, imbalance, that is that yes, no, I have no spinning sensation now, but I feel little imbalance. I feel little shaky. I feel that if I stand, my body is moving left or right or front and back. At that point of the time, you have to go for VRT. Otherwise, 90% of the patient are fine with maneuver. You don't have to do VRT at all.
Unilateral sudden hearing loss is cause of vestibular problem.
Actually, yes. Idiopathic sudden sensory neural hearing loss, if you look into most of the time, what we see is that they have a sudden sensory neural hearing loss. This also I had discussed when I had come to Vijayawada that there can be a different form of sudden sensory neural hearing losses. But remember that it's the basilar artery. From the basilar artery, you have anterior inferior cerebellar artery, and the anterior inferior cerebellar artery, you have a small branch which is called as labyrinthine artery, and that labyrinthine artery is going to the inner ear. It is getting further divided into cochlear branch and vestibular branch. Then you have also a common cochlear vestibular artery, and that is where all these patients will have sudden sensory neural hearing loss plus the vertigo issues. But what will happen is, because the compensation will happen, they initially might have a spinning sensation, but after 2 or 3 days the spinning sensation will get over, so they will not report to you with anything. But when you do the vestibular test, you will understand that they have a damage.
How long after the initial vestibular symptoms does acute compensation take place?
Around 40 to 72 hours after the initial symptom. That will say that maybe 2 or 3 days post this one.
So someone, a very informative as well as practical and clinical input. Thank you, sir. Someone have messaged. Involvement in sports activities, physical play activities, we can suggest to improve vestibular issues in pediatrics.
Yeah, sure. That's what I said that, most of the time our children are locked inside the home because, in the town or a big city, you don't know where to take the children. And, these play activities are really useful. You take them out as much as you can and you make them involve or make them play with other children. Their stress will be out. Definitely it is going to help a lot, means lot. Definitely.
So how to work with the patients who have vestibulopathy and lower limb weakness or arthritis?
Now, what will happen is that, arthritis is another condition which is very difficult to treat with. And you know that once the arthritis comes, it never goes. It is there. If they have pain, knee pain or the ankle pain, wherein they are not able to stand, then the balancing exercises will not work here. That is what you have to understand. Very simple thing. Because the source of major imbalance is the pain which is happening in the knee or which is happening in the ankle, because of which they are not able to stand. It is not coming from the vestibular source. So you have to see one patient to the other patient how it is, and then only you have to work accordingly. It's very difficult to treat the patient or go for this VRT in a patient with arthritis who are not able to stand. It becomes very difficult.
Special guidance for diabetic patients, sir.
To keep their sugar level checked, that is the major suggestion I would give them. And to other who don't have diabetic, live a good life, take some time out for your exercises, physical exercises, have a proper good sleep. That is, you find a particular sleep pattern should have. When I say good sleep, two things: one is that duration, 6 hours of minimum sleep, and second is quality, that even somebody blasts near to you, you don't understand that what has happened. So in two terms, that is the thing which I would like to suggest. Otherwise, keep that sugar levels in check.
Sir, in vestibular hypofunction, what treatment procedure we can follow?
No, in vestibular hypofunction, see, all the disorder, Meniere's disease, labyrinthitis or neuritis, they all will cause a vestibular hypofunction only. So you have to look at the patient and you have to go ahead with the VRT. That's all. There is no other this one. But sometimes what happens is that in patients with menias, wherein I told you that the VRT is not going to work, they will require symptomatic treatment from a medical professional. So whenever there is an episodic vertigo during that point of time, they need some medicine to control the vertigo, because at that time they cannot go on doing the exercise, because at that point of the time the exercise is only provoke the vertigo. So you have to look at the patient and you have to decide accordingly that whether they have to go for a medical line of treatment and they have to go for this one.
In geriatrics with mild dementia or any cognitive issues with vestibular issues, how do you introduce the VR strategies? How do you monitor the improvement?
I have not worked with such patient, to be very honest, let me tell you. So I will reserve my comment on these questions because I have not seen this kind of patients. Yes, I am seeing often the geriatric patients wherein they have this vestibular issues or the balance issues, but I have not seen with the patient and too much of dementia when there is a big problem. So I would reserve my comment here because I have not worked. I would not like to comment anything.
Yeah. So someone have texted that it's a very informative talk, sir. I believe that we need more sessions in further on both assessment and management of vestibular disorders. This specialty needs extensively understanding both assessment and management.
Yeah,
So,
actually, I'll just tell you one very simple thing. Okay, whenever we get into BSLP course, first year BSLP, and after that, the first thing which we learn is audiometry, pure tone audiometry. As simple as that. In
yes.
audiology, we learn is pure tone audiometry, and we also learn masking. And in the second year, when we go, we start doing audiometry and masking. You tell me honestly that how much time did you take to master masking? Second year, whether you were master of masking. Third year BSLP, whether you were master of masking.
No.
Whether internship you were master of masking. Only when you come to PG, you put your a little brain here and there and try to understand what you are doing is right or wrong. That is what is the thing. So here what happens is that one or two talks are not going to be very frank that it's going to give you 100% of the information. It is just that basics I can tell that okay, this is the kind what happens, but every patient is unique, and when you work on this patient, every patient you have different information. If you have 10 patients with vestibular migraine or 10 patients with menias, 10 patients with vestibular neuritis, all 10 of them will have a different sign and symptoms. You will be confused whether you are seeing the patient with menias only or this patient has some other problems. So there will be so much of variation. Even in the test result, there are so much of variation that you have to understand. When once you start working, you learn from every patient that comes to your clinic. Otherwise, this one or two talks, it's just to give you some information that okay, fine, this is the kind of things which are available. That's all.
How early can we recommend the VRT following the vestibular condition?
Uh, Say that every patient who will come to you, invariably, at least 15 days after the first symptom when it has started, and I think that's a good time to start the VRT. See, anybody has a problem, whoever has a problem, they will reach to the medical professional first. That is what you have to understand. So when they reach to medical professionals, some medicines will be given, some this one will be given. Once they are out of hospital, once they think that they are little fine, then only they will look for other option that where it is going to get cured on a permanent basis. So by the time they reach to you, it will be almost like 15 days, and that's a good time to start the VRT.
So spinal cord issues of spondylitis are common in geriatrics, or then if they have vestibular issues, how do we plan rehabilitation?
Okay, I with this I remember one of my patient. I still remember his name, but I will not reveal his name here. The patient was 42 years old and he had stroke, and because of the stroke he had both upper limb and the lower limb weakness, and there was a drooping of both the shoulders. So this both the arms were given the support so that shoulder can remain at some point, and the patient basically developed vestibular neuritis, okay, after some point of the time. And because of the vestibular neuritis, he was admitted to the hospital again, and once he was out of hospital, he was feeling too many problems with the head movements. When I saw that patient first time in my chamber, I really did not know that what to do with this patient, because the patient is not even able to stand on his own. There are two people who are required to make him stand, and there are two people to make him sit on a chair. So I seriously, I did not know that what to do with this patient. Now I knew that, okay, first a stroke and then vestibular neuritis, now what to do. So what I did is that, okay, first is that in vestibular neuritis, then definitely there is an impairment of the VOR. So now at any cost, I have to work upon the VOR. So what I did is that I put him in a revolving chair, okay, and I tied him in the revolving chair properly. And then I started, instead of moving him, I started moving the chair. So the head and the body, again, it started working like a VOR. So this is how I worked upon him, and then I asked him that, when I am moving your chair, you please close your eyes. So that I started doing that, so that the viewer, what I started working in eyes closed condition and eyes open condition. Then I said that slowly you will start moving your neck up, so that I only used to give support, and I started moving the head up and down by a slight movement up and down, so that he starts moving, and slowly he got that confidence to move on his own. So slowly he developed that movement on his own. But yes, it really took me time. By the time I was generally 3 weeks to 4 weeks, I take with every other patient, and I took almost 2 months with him to restore his entire balance function. So this is how I went on restoring his function. Now there was another patient for the BPPV. There was another patient of the BPPV wherein the patient had a problem with the spinal cord and had undergone the spinal surgery. So now the patient developed BPPV. So I really did not know, because you cannot make the person who has gone with a spine surgery to sleep and do the Dix-Hall-Pike test. It is very difficult. So the patient will always sleep on one side and then will turn to straight or go to the other side. So you really cannot perform the Dix-Hall-Pike test, but you can do the supine roll test. You can ask them to lie down on their own and then turn how they are comfortable. When they become comfortable, at that point of the time, you have to just move the head left and right to see that whether lateral canals are affected or not. But you cannot really do the Dix-Hall-Pike test. Then what I did is that I made the patient to lie down on the bed. So okay, please lie down on the bed. So comfortably, patient, how she used to sleep, she slept on the bed. Then what I did is that I turned her head approximately 45 degree to the right side, and I asked her caretaker to just hold her, and I just, and my of course some other clinicians were there with me. So I just lifted the entire bed upward towards the leg side, so that the head goes down. When the head goes down like this and the head moved 45 degree, it really gave me the Dix-Hall-Pike position in the right 45 degree and then the left 45 degree. So I understood that the person has problem on the right side or the left side. And that is how I went ahead with then the this Apaslpa maneuver also, and that patient had problem on the left side. Okay, so these are the modification which you have to think of while you are seeing the patient, and when you will see the patient, you will definitely think something. And this is how I went ahead with 2-3 patients who had this cervical issues.
So one last question, sir. What is caretaker counseling points during vestibular rehabilitation for a patient with balance disorders? What is the level of support or cooperation required?
This is a big cooperation is required, because I remember one of my patient with vestibular migraine. She had a severe phonophobia. Phonophobia is a condition where the patient is not able to tolerate the sound, basically. So I said that what is that sound that triggers, okay, that sound that, which causes you problem, irritation. Do you have any idea that, the music or mobile phone sound or something? What is the kind of sound which you think that it is a problem? She told me that I want to throw my husband out of my room because I don't want to hear his voice. Now you tell me, what do I tell her? That you throw your husband out of home? Means to say that what you have to understand is that practical issues. This was just an example, but this was a practical issues. Now if the husband gets irritated that you have problem with me and you want to throw me out of home, then there will be another issues which will arise in the family life. That is where you need to counsel them that yes, they have the problem, they have that frustration, they don't have that confidence. So you have to tell the exact problem which the patient is facing or going to face over the period of time. One, the physical problems, second, the emotional problems, and you have to exactly explain point by point that yes, this is what is the problem, and then you have to counsel. I counsel the patient once, and I counsel the caretaker ones, that what is that they can expect from the patient and what is that they can expect from me as a clinician, and that is how I counsel and I go ahead with the treatment.
So that's it for the day. And Shri Pallavi ma'am have texted that my congratulations to the team APSLPA for choosing the best speaker, Sujeet sir. He was my senior at AlISH to give talk on vestibular disorders on the occasion of Balance Awareness Week. Thank you so much for sharing your inputs. So she's listening from London, UK. Thank you so much for joining, ma'am.
Thank you, Pallavi.
So many are asking for the other more sessions to make more webinars on this topic, so especially on vestibular. Yeah, I think
we will look into the future this one, and Gopi has to tell me.
Yes, sir. Definitely, we can plan it.
Yeah. Okay. I can. I think Dell. Yeah. Okay.
Definitely more programs, sir. Webinars also.
Pardon me.
Definitely, we'll be conducting some more webinars also.
Okay. Okay.
Yes,
thank you.
Sir, so I just want to share my screen. I think we are almost concluding our webinar.
Yeah. Okay. I'll just.
Yeah. So thank you so much, sir, for delivering such an insightful talk on vestibular rehabilitation. It is not alone creating awareness about this balance awareness, but also among audiologists to provide more insights, also to provide vestibular rehabilitation therapy to all the patients to enhance the quality of life for patients. Without any further delay, I would now like to invite our Honorable President of APSLPA to deliver the vote of thanks before we concluding our webinar.
Thank you, Sucharita. Hello, good evening, everyone. Am I audible?
Yes, sir, you're audible.
Yes, sir. Yeah, this is the e-certificate for the Sujeet Kumar sir for spending a valuable time with us today on the occasion of the Balance Awareness Week. Sujeet Kumar sir, thank you very much.
Thank you so much.
There is an increase in the prevalence of the vestibular cases in our day-to-day practice. We have to have awareness on the vestibular rehabilitation. There will be a lot of new things will be happening, new research will be happening. With these webinars, we as an audiologist will be getting the knowledge on the latest rehabilitation practices. So most of the time we will be getting the patient from the ENTs or neurologists. We just do the PTAs or REMs and we'll be sending them back, and the patient goes for with the medical treatment. It's not enough. Again, the patient will come back with the reoccurrence of these balancing problems. So we have to go to the ENTs or neurologists and we have to explain them that what we will play a role in the vestibular rehabilitation, and we should give the awareness to them also. With that, first we should have also awareness on this vestibular treatment, and we should have a complete setup, or we should practice the vestibular management. So
actually, if you ask me frankly, you don't require any big financial this one for the vestibular rehabilitation setup. If I say that maximum 10,000 rupees, you can start with your complete vestibular rehabilitation setup. That's it. It's not a big thing that is required. Very small things. Very small things that is required for the vestibular. Yes, assessment, I do understand. We have to buy some equipment, but rehabilitation definitely doesn't require anything.
Okay. Thank you, sir. Thank you very much.
Thank you so much. Thank you, Gopi, and thank you, Andhra Pradesh.
And I expect everyone also will start doing the awareness on vestibular rehabilitation. Thank you for clarifying doubts and sharing a valuable content with us, sir. Thank you, everyone. Thank you, all the participants.
Thank you.
Thank you, Gopi and Sucharita, for coordinating and moderating this webinar. Thank you, everyone.